Okay, so we are ready to start, Shirley, whenever you want. So,
Okay. Well, I'm delighted to have this opportunity to answer questions from the people that have been listening to the presentation, and delighted to have another opportunity to clarify about the movement system and exactly what it means. I just want to say, as I started off last time, that I've been in this profession for 60 years. And I'm more excited about what we have to offer than I was when I started 60 years ago. And that's why I'm so committed to the idea of the movement system, because I think it will clarify for others out there, beside those within the profession, about how much we can contribute to healthcare. Okay, so the first question, which I had received a little while ago, was, what do I think about O'Sullivan in cognitive functional therapy? I think the idea of trying to assess the pain that has gotten out of control by people is an important part of what we should do in our assessments of individuals. I think in some ways the availability of radiology, where people see more about injured tissues and then are treated with things like opioids that produce secondary effects, has made this kind of assessment particularly important in this day and age. The first part was that clearly people have recognized the importance of pain science, and that being aware of how to assess people for when their perceptions or their pain has overridden whatever tissue problem they had is an important aspect of practice. I've reviewed the literature, and I've had discussions with many people, and what needs to be kept in perspective for all of this is what % of the patients that present themselves to a physiotherapist are afflicted by this exaggerated pain response. And it's in the neighborhood of 15 to 20% at the most. I think that group has always been with us, and I think what's important is to recognize how best we can deal with it. And there's one other aspect to this, and that's what I was trying to present in this material, is that with our examining how people move and what causes them pain, and how to show them how not to elicit pain with their movements, that will put the patient in charge of their pain, and it won't be so frightening. And if we start that from the beginning, before they've become so fearful that every movement will hurt, I think we can reduce this pain that becomes out of control. I think the second part of this question was how to integrate kinesiophobia concepts in with the movement system. And I want to talk about a specific study that Linda Van Dillen and her colleagues did. And this study was a study where people stood for 2 hours, and about 28 to 42% of the people developed back pain. These people were given the test for kinesiophobia before they started to do the standing paradigm. And in this study, what they found is that if you had a high kinesiophobia score, you did not necessarily develop back pain. But if you develop back pain, you usually rated it at a higher level than those that had a lower kinesiophobia score. And then the other question was, how do you correct movement without discouraging movement? And I never discourage movement. What I do is we teach people how to move so they don't have pain. In fact, we enable them to move rather than discouraging any kind of movement. And I think I'll just reinforce that that's why it's so important to appreciate it's the way you do your everyday activities. And that's what needs to be corrected, like how you roll, how you go from supine to sit, how you walk. Correcting all of those keeps people moving, and it puts them in charge, which is the really important aspect. And then another question was how to avoid nocebo. And to me, I'm always positive. I always believe I can help the patient. So if anything, it's creating a more view of success, and not to worry. We're not going to make it worse. We're going to make it better. And I know how, and we're going to help you know how to fix yourself. And then another question was, how can someone always sitting in front of the PC, even in an incorrect way, not, I guess it means in a correct way, not develop any pain? I think the secret for almost anyone is that you need to change positions. And sitting for a little while is good. Standing for a little while, as I just mentioned, standing can give you pain if you stand for a prolonged period of time. So it's moving and changing positions. That's why desks that alternate from the sitting position to the standing position are getting very popular. Okay, then just I want to answer some other questions before I go on to show the relationship of the movement system to other than the musculoskeletal system. The one question was, what is your approach with the chronic patient? I can tell you that for the most part, most of my patients were chronic patients because it took a while to get an appointment. So this is the approach with and I tend to believe that all people are chronic patients, that things start early and then they just continue to progress. So sometimes you catch them when it's early, but it's a progressive problem, particularly with the musculoskeletal system. And then just one more, and then I'll go on and we'll talk about the relationship to other systems. And that was how long did, in the pictures that I showed last time, how long did it take to get those results? Actually, those were almost immediate before and after pictures. Because again, and then the conditions continue to improve. We just show people how to move right and how to stand right, and a few key exercises, and it can make all the difference right away. I do want to add that I really believe, though, that patients should come in periodically over the course of a year, that we should see people at least every year for an exam, and we should be available to monitor their continued improvement and making sure that they get the help they need with all of their activities. So I'd like to go on and deal with this question of what does the movement system pertain to? So we'll show some slides and graphics to get that information clear in this presentation. As I mentioned, I want to clarify that the movement system does not just pertain to the musculoskeletal system, and it doesn't just pertain to chronic conditions, but also to acute ones. Didn't mean to do that. So it was in 2013 that the American Physical Therapy Association adopted this identity of the movement system. And the reason for that is to emphasize that physiotherapists have a responsibility for a body system. Now, it's not one of the basic systems like the musculoskeletal, but it is a system of systems. My own thinking about this started almost 50 years ago when I was part of a panel and was being interviewed about what physical therapy is. I was a chapter president, and happily they asked another chapter president to describe physical therapy before me, and he gave a really bad answer. But I was so befuddled that I didn't even know what I was going to say when it was my turn to explain it. And so then I wanted to say more than we helped paralyzed people be able to move. I thought we needed to have a body of knowledge that would make more sense. And it just became clear over the years that what we really care about the most is movement, making sure that people can move as optimally as possible and as pain-free as possible. And the reason for taking it on to say movement system is the way we make people move better is to attend to try to deal with how the muscles function, how the nervous system functions, all of those things that produce and affect movement. And over the years, what I've watched us emphasize as a profession is our treatment techniques. So we're known more for what we do as far as treatment, but it doesn't mean that we're respected for what we know. It's more like the doctor figures out what's wrong and we deliver up the therapy. And so what became really clear to me is that the physicians, for the most part, and I was in the Department of Neurology for about 40 years, is they don't understand the complexity of movement. The neurologists knew about what was wrong with the nervous system. So it is clear we need to be respected for what we know, not just what we do. And then if you want to pick a system to be responsible for, the movement system is a really great one because it's essential at all levels of function of the organism. So whether it's ions going through membranes, air going through lungs, how you move your limbs, or how you move in your environment, it's all about movement. So the definition of the movement system adopted by the Physical Therapy Association this past year says it's the integration of body systems that generate and maintain movement at all levels of bodily function. So it's very broad and very general on purpose. So this is the graphic of the American Physical Therapy Association. And what it shows you is that the movement system is not limited to just the musculoskeletal or nervous systems, but you can incorporate the metabolic system, the genital urinary, the gastrointestinal, and even the immune system. It also fits nicely with the biopsychosocial aspects that people are so focused on these days, because for bio, that's all of these systems. They're all physiological systems. And psychosocial, you can't have that functioning without the nervous system primarily. And the pain, like we talked about earlier, is also I don't know, that one went away, is also an important part of the nervous system. There's no pain without the nervous system. But you have to say to yourself, as a physiotherapist, with all of these systems functioning, what do we care about in particular? And it's the movement associated with these systems. And even with the immune system, which, as we know these days, almost every condition that physicians are worrying about is related to the immune system. And the most important intervention for treating the immune system, one of the important ones for lifestyle, is exercise. And I just want to go on to say, to show you a paper, this is in an article I was reading, that how to save your immune system. And they specifically cite movement and regular workouts boost immune function and lower inflammation. The article cites how skeletal muscle is the major immune regulatory organ and that it generates the anti-inflammatory and immunoprotective protein called myokinase. And physiotherapists should be the exercise experts. It's not just telling people to exercise, but what can they do safely? What can they do effectively? What's appropriate for them, considering structural variations? And so again, just to make the point, why the movement system? Well, because we're focused on the movement system and we should be exercise experts. And I think this speaks to the knowledge we have, because for the musculoskeletal system, it's about the biomechanics, the muscle physiology, and skeletal physiology. And for the nervous system, it speaks to the biocontrol, biobehavioral, the psychosocial aspects, and even biomechanics, because the activation patterns of the nervous system are really the interaction of muscle and motor learning. And of course, gravity is a major influence. And then we have the bioenergetics that arise from the cardiovascular, pulmonary, and endocrine systems. And those are the support systems, but they're also affected by movement. So that's why it's important to have all of these systems as part of our expertise, so we know what affects movement and how best to optimize it. And it's important to convey this responsibility for a body system, a physiological body system. That's why neurologists, cardiologists, even dentists have respect, because they're in charge of a body system. And then what I want to emphasize, last time I was making a point about kinesiopathologic conditions, how movement induces pathology, but clearly this is where we started. Pathology induces faulty movement. So this has always been our responsibility, is if you have a stroke, if you have rheumatoid arthritis, your movement system is affected and you will not be moving right. And then again, the nice thing about being responsible for the movement system is we can have a very big role in prevention. I think most people understand how important it is to be physically active when you're young, so you develop as much bone density as possible, so that you also have an optimal cardiovascular system. But beside knowing that you need to exercise, you also need someone that can tell you how to do that without getting hurt, without injuring yourself, so you can have it a lifetime instead of for a short time. So this little schema is just to say physiotherapists should be making movement system diagnosis. If the movement is impaired, if the movement is excessive and causes injury, if the movement is insufficient and doesn't optimize the development of the system, and that those diagnoses should be kinesiopathologic or pathokinesiologic, not what the disease is, but what the consequence on movement is. And then I think it also has a very important relationship with the ICF, the International Classification of Function. And that flow chart starts with a health condition. When the physician diagnoses a condition that has a disease or disorder, they're looking at the pathophysiology or the pathoanatomical problem, while we should be looking at the movement system disorder, the pathokinesiologic and kinesiopathologic. And that affects not just body functions and structures, but also affects activities. It affects participation. And of course, you need to account for the personal factors, which is what we try to do, as well as environmental ones. And I think a good example is if you consider something like diabetes. Now, the physician diagnoses that condition, but what we also know as movement specialists is that these people have trouble with loss of range of motion, and you can't be forceful because it injures their tissues. So when it gets to these other aspects, it's the physical therapist's knowledge that will allow them to function optimally, not the physician's knowledge of the disease. And I thought I would give you some examples. This is a published article demonstrating the use of movement system diagnosis for 3 patients with a cerebral vascular accident with stroke. As we all know, by treating patients with stroke or with hemiplegia, that they present very differently. I'm not going to go through the whole article, but the one patient, we have a systematic exam, and the results of that exam help to direct treatment, and it's also an indication of prognosis. So one of the patients in this article was diagnosed with a force production deficit, which meant that the primary problem was weakness, and that the patient could practice activities like stepping up a step, trying to do more resistive exercises to get stronger, because that was the major problem. Another one of these stroke patients had a diagnosis of fractionated movement deficit. So as all of us who have treated stroke patients know, that fractionated movement deficit really means that they're unable to isolate movement of a specific joint or limb. And so if they try to do anything, their whole arm responds or their whole leg. And in some people, if they try to do something, both their arm and leg respond. So they can't fractionate movement, which is not a good prognosis. And you're going to work on just how well can they be self-care. You're not going to work on trying to make them stronger. And then the last and most difficult of all is the perceptual deficit, also known as the pusher syndrome. So this person, the more you try to assist them, the more they push in the opposite direction. And they too have a very poor prognosis, and your treatment is going to be very different than for the other 2 kinds of problems. And then we also have these women's health conditions. And we have a what they call a section now, an academy on women's health. And this group has worked up and proposed several diagnoses. And these are those diagnoses. So intra-abdominal pressure impairment associated with overactive pelvic muscles, force production deficit, shortened pelvic floor muscles, movement pattern coordination impairment, perineal muscle tissue impairment, and perineal integument impairment, pudendal nerve tissue impairment. And so this was an article published in 2017, and it particularly cites the movement system diagnosis. Here's an example. They give a case study of an intra-abdominal pressure impairment syndrome, which they defined as a human movement system syndrome, inability to control intra-abdominal pressure with either an overactive pelvic floor muscle or a force production deficit of the pelvic floor. Those are just examples of how they pertain to neurological patients and to pelvic pain patients. And sort of my summary of this little presentation is that at least in the United States for 40 years, we've been saying that physical therapists diagnose, but we've never clarified what those diagnoses are. And I think that the diagnosis should be of what your body system of expertise is. Just like neurologists make neurological diagnosis and cardiologists make cardiac diagnosis. And it should be consistent with what our examination and treatment is, what we focus on. And I think what's really important as well is this would differentiate the scope of practice. There's always a concern, often by physicians, that we will be diagnosing the same condition they're diagnosing. I don't want to diagnose a physician's, their scope of practice. I want to diagnose within the physical therapist or physiotherapist scope of practice. So if you're making a movement diagnosis, you're not making a physician's diagnosis. But I just want to also stress that I hope that physicians will make these diagnoses, that they will say, I think this patient has a flexion syndrome. The first person to actually read my book and comment when it came out was a physiatrist saying how useful this was to have these movement diagnoses. And as I mentioned the last time, in the United States, physical therapists get a clinical doctorate degree. And I think when patients go to a doctor, they want a diagnosis. I think when they seek help from a practitioner, they want a label that tells them what's wrong, just like when they go to a medical doctor. I think the other important thing about having movement system diagnosis, it lets other health professionals and the public know about the understanding of their condition. We're alerting them to how movement plays a big role in their health and in their pain problems. It also tells people how physical therapy treats cause, not just symptoms or consequences, even the cause of the movement disorder, not in the brain, but in the manifestations in a stroke patient. And then this all important thing, it kind of supports what we know. And I don't think anybody's going to think we figured something out unless we use a label for it. In the United States, we have a great problem because there's such variability in practice. And when people are trying to show that physical therapy costs less than other types of intervention, it's hard because the variability is so different in what kind of treatment the patient receives. So having a label that helps to direct what we're trying to treat would help to improve outcomes and decrease variability. And then I kind of turn it around in my own mind and say, where would our health be if physicians did not use labels?
E l'ultima provocazione è: dove saremmo oggi, la nostra salute sarebbe oggi se i medici non avessero usato delle classificazioni diagnostiche, delle etichette?
That's my big long answer to this question of what does the movement system pertain to? And maybe there are other questions before I go on with some of the ones I've received.
Okay, so one of the questions that we received is, how is it possible to address a correct motion without compromising or considering something that is required for a sport, for example? So you need a certain movement to do a performance, and how can you address correct movement in that condition?
That's a really good question, and one I struggled with for a lot of time. And I think the question is, are the adaptations that someone makes for sport necessary for that sport, or is it going to lead to problems down the line, injury down the line? And I did worry about that, but I am well convinced that if you keep optimizing their function, their movement patterns, they will be able to play more effectively and for a longer period of time. I'm going to give you an example that struck me early on. For some reasons, I don't know, St. Louis had a lot of Olympic level speed skaters, because I don't know why we would, but we did, Olympic level speed skaters. And I saw one of these speed skaters before I really knew what I was doing. And because he always skated around the rink the same way, and that's all they did, he had the outside of one leg was all hypertrophied and the inside of the other leg. And then on the medial side of one leg, it was real small. And on the lateral side of the other leg, it was real small. Would you believe he had knee problems? You know, and I blanked on his name, but there was a speed skater who won many, many more. His first name was Eric, and I can't think of his last name. And he trained on a bicycle, so he stayed symmetrical throughout his career and won many more gold medals than anybody from St. Louis. And then there's Tiger Woods. And I remember reading about how much rotation range he had, which seemed good for his sport. But do you know how many back surgery he's had and how much knee surgery he's had? Because he overdid the motion in one plane and didn't address keeping it all symmetrical. So I think there are adaptations that are made, but I think optimizing how the body functions allows people to go on without developing a musculoskeletal problem.
So it's I'm trying to shorten the question. The question is about the adaptation in the central nervous system, depending from impairments related to, let's say, an injury or after a surgery. So we talked about the how movement can influence the pathology, but in case we have a pathology that is causing a difference, a modification of the afferent signal to the central nervous system, how can we balance the two things? So knowing that we are aiming to improve the movement quality, but also considering that we have a factor that is going to influence the way that the central nervous system is getting the afferent signal from the periphery. For example, an amputation or osteoarthritis or osteoarthritis.
Well, I mean, that is the important point, because the afferent information coming in from the periphery is strongly related to what the adaptations are in the periphery. If you take someone that has overdeveloped abdominal muscles, if you ask them to lift something up, they will sway back and use their abdominal muscles and not use their back muscles. So what you're doing in the periphery strongly influences the nature of the afferent information into the central nervous system.
Okay. Thank you.
One of our colleagues did a really interesting study, and that was to look at how the brain adapts to resistive exercise training. And they did it with an array of EEG electrodes, and they used a leg press. And I think the interesting question is, when the muscles in the lower extremity hypertrophied, did the area in the brain be more responsive, or was it a smaller area? The area gets smaller.
Okay, one of Carlos' question is about since observing and understanding the movement pattern and how the person is moving or standing or how the segments are aligned, what is the criteria to define what should be the optimal movement, for example? Because this is still open to debate. For example, let's take the scapula. So there's people around that say that the scapula should stay higher, and other people that are training patients or athletes to keep the scapula lower. So one of the interesting points should be to understand what is the definition of optimal movements. So what should be considered as standard or optimal?
Well, actually, there's a number of papers and people that look at, they take measurements from a number of people and look at where the scapula sits optimally. And I think it's between T2 and T7. And if it's too low, then you already put the glenohumeral joint in abduction. If it's in some ways, I'd rather have it too high than too low, because you don't get as many complications. But there are standards for about where it should sit with a amount of standard deviation. So one thing is, where does it sit? And then the next thing is, how does it move from there? But there are standards.
Carlo is closing the live on Facebook. So if you, Shirley, wants to say goodbye to everyone or bye to everyone.
Well, thank you again for giving me this opportunity to clarify concepts about the movement system. I think if the Italians move ahead with this, they're going to be setting precedent for the rest of the world to recognize what physical therapy is about and to have strong recognition of what our contributions to healthcare can be.
Ha detto che saluta tutti e ringrazia per aver dato quest'altra opportunità di presentare i concetti legati alle disfunzioni, al sistema di movimento, e che pensa che se in Italia ci portiamo avanti su questi aspetti, gettiamo veramente le basi per la progressione anche a livello mondiale, diciamo, della fisioterapia.
So thank you for the opportunity.
Grazie a tutti per l'opportunità.
Grazie a te, Shirley.